Let's talk about Creutzfeldt-Jakob disease. So this is a disease that is caused by the misfolding of prion proteins due to mutations of the PRNP gene. Creutzfeldt-Jakob disease, or CJD, is the most common prion disorder, with the sporadic form being the most common form of that, and it's thought of as an acquired disease. So we will be speaking mostly about the sporadic form today, but there are other forms as well, such as the genetic form, which can be caused by familial mutations in PRNP. There's also an iatrogenic form that has been obtained from surgical procedures in the past, but it's pretty rare now. There's also a variant form that's rare and is primarily presenting with psychiatric symptoms. The mean age of onset of CJD is 62 years old, although it can affect any age. So the main problem in this disease is that there is a change in the secondary structure of the prion protein due to the mutations in the PRNP gene, and this causes a conformation change from the alpha helix secondary structure to a beta sheet, and that's what causes the neurotoxicity. These abnormal prion proteins replicate over time and replace the normal prion proteins, and since they have to replicate over time, there's typically a long incubation period of years. So clinical features, this is going to be a more subacute onset disease, so you won't have symptoms for just a day or two. Typically in an exam question, someone will have had symptoms for at least several weeks or months. The most important symptom to know is progressive dementia. There can also be visual hallucinations and akinetic mutism, which is a later symptom. Some earlier symptoms can include impaired memory and concentration and behavioral abnormalities. One symptom that is commonly tested is myoclonus, which can particularly be provoked by startling them. There can also be cerebellar signs such as ataxia and nystagmus. There can be upper motor neuron signs. They can have hyperreflexia and spasticity, and there can also be extrapyramidal signs such as Parkinsonism. For evaluation, the evaluation is very important because there's not much in the way of treatment, so most of the test questions will ask you about the evaluation. So MRI brain is fairly sensitive and specific, and will show a hyper-intense signal on the DWI and T2 sequences, and these actually also appear pretty early on in the disease as well. So cortical ribboning is something that you can see. It'll be hyper-intense around basically the rim of the cortex. And other commonly involved areas are the caudate and putamen, seen here. These are DWI images. The EEG will show periodic sharp wave complexes that are from half a second apart to 2 seconds apart. So they'll look like this. Sharp wave, sharp wave, sharp wave. The CSF evaluation is very important, and the RT-QuIC can be diagnostic of the disease in just the presence of the neuropsychiatric symptoms alone. And so what RT-QuIC is that if there is presence of abnormal prion protein, it will undergo a conformational transition in recombinant prion protein, and that forms amyloid, which is tracked in real time, and that will give you a positive RT-QuIC assay. There are also other adjunctive findings that include a positive 1433 protein and elevated tau. The adjunctive findings can become important in diagnosis when there is a negative RT-QuIC, as RT-QuIC is not 100% sensitive or specific. Histology. So a brain biopsy is sometimes done to rule out other diseases, and an autopsy is also confirmation and definitive diagnosis of the disease. So on histology, you'll see spongiform changes, so kind of vacuoles here. And one thing to note is that there's not really going to be any inflammation. So you'll have neuronal loss, but there's not going to be a lot of lymphocytes in the surrounding brain tissue. It's going to be pretty bland. If you do immunohistochemical staining, you'll also see accumulation of abnormal prion proteins. For treatment, there is no disease-modifying therapy. However, supportive care can be helpful, such as if they have myoclonus as a bothersome symptom, then clonazepam or other anticonvulsants can help as well. For psychiatric symptoms, sometimes psychiatric medications are used, and end-of-life services and planning is very important as well, as these patients do not typically live long. In fact, death usually occurs within 1 year of the onset of symptoms, with the median duration being 6 months. And younger patients will have a more prolonged course, but they will also pass away.